This episode is about the AI impact on disease and health issues detection. I will discuss this with Lara Gervaise, who is the founder of Virtuosis.ai. So after going to MIT and working in the Silicon Valley, Lara Gervaise founded Virtuosis, which is a startup using deep learning, so AI, to detect health issues, ranging from burnout risk, stress, to mental health issues, or even diabetes. Eventually, this type of models could highly lower the cost of detection, some potential health risk, and then get a diagnostic. But of course, many challenges that we are going to discuss here about accuracy, the capacity to generalize, and even social barriers. This is the AI Impact Podcast.
Hi, Lara. It's a real pleasure to have you and to discuss about Virtuosis, and in particular, your very interesting project that I've been discussing with many people actually since we've met during Digivision. Your project, Virtuosis, and your work these days is about detecting health issues with voice using basically AI and in particular machine learning, deep learning, if I'm not mistaken. So can you tell us a bit more about this? Just first, for people who never heard about you and about this idea, what is it about?
Yeah, sure. So, Virtuosis is about detecting health insights. So, not just health issues, but measuring health such as stress, but also diseases such as depression, Alzheimer's, diabetes, and much more, just from audio recordings of speech, like conversational speech, like we are discussing right now. And we just need 30 seconds.
And how did it start? How did you come up with this?
So it started during my thesis at EPFL. So I'm an engineer by background. And there before AI was the hype, I wanted to use AI, which I was calling machine learning at the time, to predict how we feel. And so I started collaborating with psychologists in the beginning to map not just voice at the beginning, but also body language, facial expression, what we say, and not just how we say it, to how we feel. So how we feel, there is one side which is about emotions, and then there is everything about stress, anxiety, happiness, etc., which are not that tangible. And so I wanted to kind of quantify this. And when I started collaborating with psychologists in the beginning, solid ground truth. So we could train models on it. If you don't have a solid ground truth, you can train model, but it won't work well because the baseline is not stable or just you're not predicting something that makes sense. And after discussing a lot and looking at different definitions, different philosophy behind affects, I started discussing with psychiatrists at CHUV, at the hospital. And there I discovered that, okay, there is depression, for example, anxiety that have a given definition in the DSM-5, which is the doctor's Bible. And they have really a unique way to assess it. There is a standard protocol that you do, guided interviews, and then also on the screening side, there are patient-reported outcome measure like PHQ-9, PHQ-7 that are used. And so this was a solid ground truth to me. And then that's how we started doing prediction about mental health. And in parallel, combining all the feature, we discovered that voice alone was the best predictor. And so that's how we focused on voice. And ironically, before I was working on a previous startup, looking at detecting distress in the voice of elderly people when they would try to call for help, but won't be able to articulate. And so that's maybe a beautiful coincidence, but that's how it started.
So that was exactly what I was going to say, ask, because you mentioned visual cues, and then basically here it's very interesting, and you very well explain it. Why did you focus on the voice? And something that might surprise people, and I was surprised about this, the first time I've heard and we discussed was you mentioned first a few things where I guess anybody can kind of have an idea of what could be the cues, or what you can detect, for example, stress, or things like this. And maybe we are wrong, but it's easier to make sense. But then you mentioned other type of issues that might be surprising to the audience as well, like diabetes. And again, here, how did you come up with this? Is it something well researched already? Was it by chance you realized that maybe let's try, based on some data sets that you got your hands on, or where does it come from?
Yeah, so not so spinning up Virtuosis and becoming like a private company, we're not anymore a research institute. So we would only look at things that have already been at least proven in some parts to work. And so that's not based on my personal intuition, but on what I came across in the literature. And so, for example, Parkinson's disease, that is the first area which was explored using voice, what we call today vocal biomarkers. And since then, there have been a lot of studies also on respiratory issues, particularly during COVID, where there was a lot of funding to look at other ways to assess COVID beyond this antigenic test at scale. And voice actually performs better. But the time it gets approved, it was too late. We're not talking about COVID anymore, even if today people are still getting it. And since this period, it's like the research has exploded on the field. And there has been a lot of research, including on diabetes, in particular from the Luxembourg Institute of Health. And that's how we started exploring more and more disease.
And what type of biomarkers are COTS basically? Is it something that we could hear or you can explain, or is it way more complex? So I guess you use deep learning, right? So maybe just try, we can dive into more technical things, but let's start with like broad picture, general audience, and then we can also go more technical later.
Yeah, so for example, for depression, if you discuss with a psychiatrist, an experienced one, they will tell you that they can immediately hear if the person is depressed or not, and that is even unconscious. And after doing a lot of analysis on voice data of depressed speech and undispersed speech, I can also hear in the voice recording without having a label if the person is depressed or not. Once I played that game and I performed quite well as a human even, but with like automatic voice analysis, it's much more sensitive than our ear. So it's you can even detect more subtle types of depression, and it's the same for Parkinson, for example, where in the voice you can detect much earlier than the first tremors. And if you do, for example, for diabetes, there personally I wouldn't hear it. I'm not aware of professionals being able to hear it. Maybe some laryngologists could because of their experience and sensibility, but what we call voice biomarkers, they are really this audio feature that have been mapped to physiological changes.
Okay, so it's not necessarily like breaks or you hear the breath. It's sometimes something more subtle than these cues that are just caught by the deep learning model.
Yeah, and it's a combination, like a
Okay.
signature. So, for example, in diabetes, you will have the specific features that are impacted by respiratory fatigue, which is you need some breathiness in the voice, but then you have that combined with the vocal cords, which tend to be damaged because of the gastric reflux, combined with the impact of hypoglycemia on the sound of the voice, and then again with neuropathy, which impacts more on the muscles side. So it's really the different feature together, which deviate from the norm in a certain direction. That's the signature of a specific health outcome.
Mhm. I want to come back to something that's not necessarily, not everyone maybe understood why it's so important. Having the ground truth when you train these models, because this is typically one of my questions. You basically need to have something where you know the ground truth, meaning you have some cases of people you are for sure they have this health issue, and other who do not have, and you have voice recording, allowing to train your model. And basically, so again, just to be sure that everybody is on the same page in the audience. So how accurate are these data sets? So basically, you had access to large data sets with very high accuracy about the ground truth. Is it correct? Or?
So in the data set, the best ground truth is a diagnostic of the person. Of course, you can have some misdiagnostic, but depending on the disease, there is less probability or more. For example, in depression, you have higher probabilities of your diagnostic. And so that's what we aim for in terms of data set, to the voice recording and the true diagnostics. And then, especially when you use deep learning, which are the shallower models, you need a lot of data, and the performance increase as you get a lot more data. And so there, it can be beneficial to have this lower quality data, uh, but which means not diagnostic, but approximation of it, like patient-reported outcome measure. But you can get such data on a much larger scale. And so that's what we do. We cannot do it for all disease because they are not this approximation for all disease, but we try to, and we see it improves performance.
And did you also to benchmark your models? So basically afterwards test basically the accuracy. So basically also let's go in this direction because I have several questions in this direction about accuracy. Because well, let's start with something. The first piece. What is typically the accuracy of detection you have with your these types of models?
So it depends on which insight we are measuring. So what we release, we always aim for really at least 80% accuracy on a balanced data set, because otherwise accuracy doesn't mean much. And then we play with the sensitivity, specificity, so how many false positive or false negative we would have. And depending on the use case, we would maximize for one or the other. So do we want to not miss any case because there is a double check, or do we want to minimize the false negative because we don't want to put a heavier load on the healthcare system? So it really depends on what insight and how it's deployed. And then we really have the standards before releasing a model. And then also generalizability is very important, because you can have data that has been recorded always in the same room, and then when it's used in different room or in your phone in the transportation, it won't perform as well. So that's where also we put a lot of effort, and sometimes it's better to have a lower performance but a better generalization, because if you have a model that performs, let's say, 98% accuracy, sensitivity, specificity, but then when you use it in the real world, you can have like really a drop of performance to like 60%.
Yeah, exactly. So basically, then you also track the real world's accuracy, but because you know way better than I. But basically, again, for the audience, you have sometimes in predictive inference, like with deep learning, you have the models who will catch. They will have very good accuracy in training because they catch something that actually is not really useful. Very simple example, it was in medical research on, I think, some images to detect some tumor or some health issues, again with MRI. And the deep learning model had like a 98 very high accuracy, but actually it caught the parametrization of the machine, because they gave to one machine with some parameters a set of positive case, and the false positive, the null case, basically no tumor, were from a different machine with different parameters. And so actually it was very powerful at just capturing the source of the images while not actually really detecting tumors. And again, here, as you mentioned, you have different source of data, some with higher, better quality, some with lower. How do you ensure that it's also accurate in real life? Do you also match with, I don't know, diagnosis in the second step, or how did you do this?
Yeah, so there we can categorize people in two like ways of thinking about it. There are the people who are maximizing the performance, and they are like, this is deep learning. We don't care about how it works, just it performs, and even if the correlation doesn't make sense, I just care about the performance. The machine knows better than us. They are that kind of people. And then there are the people who focused a lot on explainability, even if they get lower performance. And I think I'm on the explainability side, but for some types of problem, which I don't think medical problems belong to, this way of non-explicable way of thinking can sometimes be better. But we focus on the explainability, so every time we try to understand, we analyze what are the features that have the biggest correlation with such health outcome, and what is the physiology behind it that impacts this voice feature. And we make sure it's not picking up something that we don't understand the correlation. And that happens especially when you have data set that are in certain conditions. So you mentioned with imaging, so that could be linked to the machine, for example. And you could have, for example, if it's a data set that is gathered in collaboration with a hospital, you could have in that neighborhood where there is a hospital a higher density of people with the disease in question. And then you would just learn the parameter about the acoustic of the room, but this is just a correlation that doesn't make sense. And when you deploy in the real world at large scale, this correlation that the models made will have a bad impact on your real world performance. So we always first train a model that is explainable, machine learning, and with also voice feature we can separate, and then we train a second model that is less explainable, but that really improves the accuracy. So that's the way we work, and then we really measure how it's performing also across languages to make sure it will generalize well, because although we focus on parameters that are not depending on what you say, but really how you say it, you have some difference in the way you speak. For example, in Chinese, the models tend to perform better because just the phonation, how it is in the language. So there are variations still across language, and it's important to have at least a few languages in the data set so the models learned parameters that are independent of the language.
Yeah, and then you're basically going directly in this very important follow-up from accuracy, and you mentioned the capacity to generalize. And because usually we discuss this as well, like biases, and in research you have these weird biases in particular, not in particular, but social science, also medical research, where you focus on maybe Western world. So the weird bias refer to Western educated, industrialized, and etc. So basically one type of the world. So within your data set, you also ensure that you have a good representation of men, women, different origin and different languages, right?
So sometimes we exclude people from the data set just to ensure it's balanced in terms of gender, in terms also of age, in terms of demographic. We try to balance it as much as possible. This one is harder. And then, for example, for diabetes, one parameter that is important to balance is BMI, because just from voice, actually, we could somehow predict the BMI, and there is a correlation in itself between BMI and diabetes. And if we were not paying attention to that, we could just be predicting BMI instead of diabetes in the end.
And why demographic is harder?
Because in terms of demographics, I mean balance in terms of ethnicities, language, etc. And that depends with whom we manage to have partnerships, with which hospital. And so, of course, for us being in Switzerland and in the French-speaking part of Switzerland, it's much easier to get partnership with a hospital in Switzerland, in France. And so we have a lot of data in France, but then we ensure to have a partnership across the world. So for example, we have one in Korea, one in the Middle East, also in different European countries like Spain. We also have in Canada, US. So we try to be as diverse as possible. But for example, in Africa, that's we are currently working on partnership there, but we have less data there.
Mm-hmm. And still thinking about accuracy, before going further, you mentioned this kind of 80% at least of accuracy to use a model or go further with this model. Um, how does it compare to other methods? So basically, because here I guess the whole point, and you'll tell it better than me, but I can imagine that the whole point is that there is a relatively low cost for detection. So even if it's not so high compared to other methods, it's just that you can scale at a relatively low cost. But how does it compare, generally speaking? What's the kind of pain point you're trying to solve, if you want, in disease detection?
Yeah, so our goal is really to make health screening as accessible as possible, so you can do as often as possible, ideally at least once a week. And to achieve that, we have some integration into telecommunication platforms. So, for example, right now we are putting in place a project in France where our AI is integrated in the background of the telecommunication the elderly population has with the caregivers. So there is like a regional program where they have regular communication. They also have like a button in the room where they can call for help. And there, no matter why they are calling, we will analyze for health issues in the background of the schools. So that's really effortless. Of course, the person has to give their consent. If they don't want, they won't have it. But at least it's there if they want to use it and without any effort. And it's the same in the background of teleconsultation. And when there is no integration on the, let's say, on the map, we have our web app where you just need to talk 30 seconds to your phone. So it's really easy. 30 seconds is not a lot of time, and you can do that regularly. And so indeed, even if the performance is lower, and the performance will always be lower than the like diagnostic run-throughs, because we can only try to approximate as close as possible to 100% the ground truth we aim to predict. But instead of, for example, for neurodegenerative disorder, instead of doing all the imaging, MRI, which takes months to get appointments, you can do it immediately. And one of the neurologists who is using Virtuosis in teleconsultation said, for me, it's like a scanner, but the results are like instantaneous, and I can take into account these results during the consultation I'm having. And so I think that's really the power of it.
And what type, for example, for this example, when you roll out either with a therapist or for the elderly population in France, how long is the list of disease health issues you're trying to detect? Do you focus and narrow down to a handful, or is it really like you have the full scale every time and it's I don't know many?
Yeah, so first we aim to tackle now it's a bit over 25 diseases, but we don't have them all validated as of today. So we propose the full panel, and then it really depends with which partner we are working. We prefer to release the insight where we are sure there is the support behind that can be offered. And so we have most of the demand we have is for mental health, and that's also one of the biggest issue right now in our society, and there is also a lack of awareness about it. And then it depends on the population. So if it's an elderly population, there we would roll out Parkinson, Alzheimer's, cognitive impairment, for example. If it's a younger population, they are not really concerned. And then it's really what they have the support for, and also sometimes I'm not sure always why, but sometimes the partners will be working with, they have an interest on particular disease, and probably because they don't have the infrastructure to take care of, for example, diabetes, they don't want to have the insight because that would put the finger on something that is someone who's at risk, and they won't offer the support basically.
And so when you said you don't have for the 25 the validation, it means this second step where you can test in the wild with new data, basically not just in the training to be sure. Okay,
Yeah.
you hit accuracy. Okay, I see.
We don't
Uh,
have enough data on this. We have a few data set, like especially clinical data set together with hospitals, but we don't have data set on really various scenario, like during consultation, self-recording on a phone, etc. And so we don't want it to be used in setup where we couldn't ensure its reliability across different demographics, different use case, etc.
And now so for mental health, it's particularly interesting. I'm not sure, but personally, I think it also potentially brings some. It lowered the barrier to entry if you want to get tested, because probably there are some social sometimes costs of saying, okay, probably I have this mental health issue, or maybe just you are not aware that it's a thing, or what could be the signs. And here, by lowering this cost of being tested, it could be just social pressure to say, okay, I'm going to get tested about something, some mental health challenge. I guess that's one typical aspect of what you're doing that I think is fascinating. If you can really scale this type of analysis to just give the insights to anyone virtually at very low cost. And typically, who are the people paying? Basically, is it governments, healthcare system, governments, or private hospitals, companies?
It depends on the country. So there are public and private hospitals, but yeah, public government in the end. We also work with insurers, not to decide to insure someone or not, but really as a replacement or in addition to the prevention campaign, where typically you have a form and you reply to some question and then it tells you your risk. And people hate filling forms, and so they don't have much engagement in it, and so not much return on their investments in their prevention campaign. And actually, initially, that's why most of them reached out to us. And as an insurer, they really have the data of how much it costs them to not early detect disease in their insurees. So then that's one of the, let's say, big payer, but then there are hospitals who use it directly for themselves for triage or as diagnostic support. We also have national campaigns. We also have private hospital. And then we also have our app is available also directly to consumers who want to directly take ownership of their health. And on this app, we are planning to release more and more, make more and more health insights accessible. We're just careful on how people use it, so they use it really seriously and seek for help if they are at risk, and not just use it as I don't know, like a fun thing that they would share on social media.
Mhm. Yeah, I'll definitely share the link with the audience to your websites such that people can test by sharing a voice recording if they want. But you mentioned for insurance, because I guess that's also something sensitive. You mentioned it, but just to be 100% clear about this, it's about prevention. When you are within already some program within insurance, it's not necessarily to reject someone where basically instead of filling a form and saying I have this health issue, because here I guess accuracy becomes a different game, right? You really don't want to make a false positive and reject someone who don't have a health issue. So that's what basically you meant, or not.
Yeah, on one side, maybe, but mostly because of the purpose for which this technology is used, and really want it to be used to avoid misdiagnostic, delayed in healthcare, more than to choose who to insure or not. And it's really, with such a new technology, it's difficult but important to build trust, and we don't want to lose the trust our users have in us. And so that's why also we are selective in terms of the use cases we address.
Mhm. I see. And for the models, is it your models you train you with your company, your models? Okay. And you start from scratch, or do you start from, I don't know, some available model from research, or how do you do this?
So no, so we apply more or less the same methodology across disease and health outcomes, and there it's really models trained from scratch. because we focus on acoustic parameters. We don't need this heavy models that like the large language models. So it's a lot more lightweight, and we can train them ourselves.
Mhm. Yeah, yeah. No, so working with text is usually easier, I guess, than voice, which is very complex. But compared to a large language model, which is to generate text, it's indeed a different game. But I guess for predicting, I don't know, sentimental like NLP with text compared to voice, it's maybe cheaper to do with text. No.
No, it's just doing a transcription. Like there has been a lot of evolution in this field lately. You need to do the good prediction today. The models understand the context, etc. You have different infrastructure, different architecture without entering into details. And to do a transcription, the model to perform well, the model is heavier than the models we have, which analyze just the para linguistics. Now they can be judged more complex to build, and also the data we have much less data. We can just take like all the text on internet, but we need actual data from patient with diagnostic. That's really the complexity. But in terms of size of models, because it's the feature in the voice, and although we analyze hundreds of feature multiple times per second, is still less weight in the model, less parameters, like basically smaller models than what you would use just to make an accurate transcription, actually. So the benefit is that it can easily run on edge, on device, preserve privacy. So that's a big benefit of that.
And actually, you already built maybe other apps, but you have something that can be included within Teams, if I'm not mistaken. Can you tell us more about this?
Yeah, so the first product we released, which was in January 2023, is a plugin on Teams, as you just mentioned. It was during this COVID period, so Teams was getting a lot of traction and meeting were moving a lot online on one side, and on the other side, we needed 5 minutes of speech at the time, not 30 seconds. And so the way to get a 5 minutes of natural speech, not because if you talk alone to your phone for 5 minutes, you will not sound weird, but you will sound differently than a natural speech, and the model won't perform really well. In addition to the fact that like I'm not able to talk alone 5 minutes to my phone, and so we release it on Teams also, so you don't have effort to dedicate to that, and the that's really the benefit. You don't have to think about it. It runs on the background. You can check your results. You have your trends. That's really good, and especially for mental health, which can fluctuate a lot more than your physical health. And on the other side, there are a lot of privacy concerns because Microsoft Teams is an enterprise product, and so there is a fear of surveillance from the company. Although actually the company don't want to know the individual data because they don't want to feel accountable for not doing something if someone is going to burn out. But as an employee, you would always have this fear that maybe my employer is receiving my personal data. So that's one of the challenge we face, and we do a lot of, when we do a deployment, especially in Microsoft Teams, we do a lot of communication to ensure people understand that first, it's technically impossible that the employer gets the individual data, and that it's really for themselves as a benefit that they can decide to use it or not, they activate anytime. But with the web app, it's usually there is less this concern because also we can find ways to have the with not their own email address, for example. So it's completely anonymous, or you can even create, now you have a lot of tools to create kind of fake emails. So we cannot it cannot be tracked to you, the results.
Yeah, I could imagine people being scared. Indeed, that's you get the early sign. The employer get the early signs and decide to fire before someone is in sick leave, for example. So I guess here, indeed. So how do you manage privacy? Because first, as you said, it has to be anonymous, but also you're getting, if are you getting all this data somewhere within your company? Because it's probably industry secrets or information in the businesses, which I guess usually business are sensitive to this. So how do you deal with the security and privacy about this?
In terms of the information, indeed, that's so on the well-being side, it's not considered medical. On the medical side, it's health data and it's highly regulated. The strictest is France, where we have to obey to a lot of standards in terms of not just where the data is stored, but how it is stored. Is it stored on what is qualified as health data server? There is everything about GDPR, the right to delete your data, to request what information we have on you, and also the fact that there is not a risk of breach. So for that, it's not just about encryption, but it goes much further. So and so also inside the company, like so not like nobody can just like access all your health data when we have the clinical data about you. So there are a lot of rules, a lot of standards that are on that. And then there is a regulation about medical device, which we are. And there, again, it's a lot of documentation about our processes and the impact our technology can have. So there is a lot of regulations in place, a lot of documentation to do, a lot of rules that we follow. And we even go beyond that because of the ethics standard we have.
Do you know how many people got a diagnosis later thanks to your company?
So we have studies ongoing for that. So it takes a bit of time because we need, and also in terms of ethics approval, it has been difficult for the studies because you need to know if you really detected something that wouldn't have been detected otherwise. You need to detect it and not tell the person. And that is unethical challenges, but that would be the only way to really know about that. So today, what we measure is what we detect, which the person wasn't aware of. But maybe they would have detected it 1 week later. We wouldn't know. The only way to do it would be to do such not that ethical study.
But if, for example, you offer your service to a random sample in the population, and you then track them, basically detection, and then if they go further, because from what I understand, it's maybe mainly for flagging, and then you need a real actual diagnosis from a professional. You could still try to compare to a random group in the population not entering your program with similar characteristics, and comparing with detection rates and this kind of things. You could probably have already some insight like this, no?
We could, but we would need such a large sample to make sure it's not just a coincidence. And then it's hard to balance all the parameters, especially you have like demographics, like in terms of how easy is it for this person to access care and early detection. And so I think such study would be even harder to put in place. And in terms of reliability, I wouldn't be sure. That's the thing when you deal with human health, you like every intervention, everything you do has a really important consequence. And then every study you do, it's just controlled to some extent. And so you always have some margin of error.
Mhm. Yeah, I see. And is it possible to fake? Did you try, for example, here I'm not sure because with all the safeguard and guardrails you have, I'm not sure that that I would see a reason why to do this. But let's say, for example, for some reason you want to fake flagging for burnout, depression. Did you try to trick the system or?
Yeah, so for burnout, we would look at many different parameters because burnout in itself is not something we measure. Burnout is linked to work, so we can't know the reason, for example. But when measuring stress, anxiety, fatigue, depression, if you want to fake all of this at once, I'm not able to do it. But because I have the understanding and or AI engineers as well of what are the feature would have the largest correlation for in particular for depression, that's one we could try to fake, not that reliably, but we can try to. For the other disease, it's much more complicated. And when you look at burnout, like I'm not able to fix stress, anxiety, fatigue, depression at the same time. And again, in terms of why it's used for, nobody has a reason to fake it.
I see. Yeah, exactly. Uh, do you have sometimes people who say it sounds too good to be true, and if it's the case or not so much?
It's the case for when we mention all the disease and all the health. I don't like me talking about disease, but all the health insights we are working on. For some, it can be like, yeah, it sounds too good to be true. Now, when it's about the technology and vocal biomarkers, we start having more and more awareness about it. We start to see even articles into really mainstream media about it. And so, as opposed to when I started in 2019, um, people are like, yeah, that kind of makes sense. While before ChatGPT, let's say, uh, people were not even questioning it just because I think they just didn't believe it and just didn't put the effort in questioning it. That's my perception. But now it's, yeah, most people like it makes sense. It's more about the such a large spectrum of things we can analyze in the voice. That's surprising. And some people, especially in Switzerland, where we tend to be really focused, really good at one particular thing, there some people can be like, yeah, so many days, so many like health insight. It can sound too good to be true.
And what's your answer usually? How do you go about it if someone raises the point?
I mean, for me, it's the same process. Of course, there are some where we have higher accuracy, other where there are lower accuracies, but it's the same process. So if they are studied correlations, and for example, we study also women's health, and there are correlations between voice and hormones, which have been studied for decades. Applying AI is new, but measuring the difference in terms of the audio signal has already been done for decades. And so if we have observed this correlation already in many health outcomes for decades, why would it be possible only in some for some disease and not for others which have the same background? So that's, yeah, that's my very Cartesian way of thinking, probably. That's what I reply.
And so how far are you now? So you have some already clients in different countries, from what I understand. And what's where are you heading, or what's your goal now with Virtuosis, the next big step, or where do you see basically Virtuosis going ideally?
So we are really focused on increasing adoption. So that means a lot of partnership. We like to partner, not just do everything alone. And we are making a lot of progress lately on that, on the one side. And on the other side, it's widening the number of health insights we have validated. And so in terms, yeah, of vision, it's really offering as a screening as wide as possible from single audio recording, which can be done in the background of conversations. But all of that while respecting consent, privacy, and everyone also has the right to not know their health status. Some people have this desire, and respect it.
So, and your service online, so anybody can connect and try. And what type of health situation, or not only disease as you said, but what could be detected with this tool, and is it free?
Yeah, so people can go on Virtuosis.ai. There is a free version where they can just record their voice on their phone or laptop and then get their insights about well-being. So that's what, as of today, that's what we offer for free and to everyone. And we are looking to see how we can add even more health insights as we observe how it's used. And based on what we have observed so far, we really think in the coming months we'll be able to offer more health insight in this app. And we try to make everything, if possible, available for free. And so in this case, you just have to answer a few questions. And otherwise, we have the paid version where you don't have to fill any form. So it's up to you.
Okay. And what are the biggest challenge you see so far to keep scaling? Is it rather mentality, like people basically fearing some issue with privacy that you address, or with other issues, probably many people who don't want a diagnosis, I don't know. Or is it the data? What is the biggest barrier for you at the moment?
So I'd say most people want to use it. And then as I mentioned, like there are the people concerned about privacy, like for whom in terms of our app that is widely available, there is the paid version, and the ones who are okay to share a few information with them. So we can evaluate continuously the performance of our model. There is the free one. So here, depending on your level of let's say of worry about privacy, you can choose. And usually what we get is people who don't want to know about their health, but that's like not even 1% of people. They are the people who are concerned about it in the scope of the use by their by their company. And which, I mean, I understand, especially when you don't master the technical infrastructure behind you that can be natural. But when you understand the motivation of the employer, then you see that actually they really don't want to have access to the results, no responsibility there. And
Mhm.
then there are, yeah, I'd say that's the two main, yeah.
Also, I've been discussing also on the podcast with one person, Matteo, who founded Safe Space Research and Safe Space app, which is a LLM-based app to support mental health. In this case, it's specifically for students. And there are plenty of apps growing like this, from Headspace for basically mindfulness, meditation, to Leven to do CBT, cognitive behavioral therapy, with an app. Did you envision also the inclusion? Because usually in this app, you also, or some of these apps, you do have a chatbot. So what if, in addition, did you already study this combination? Basically, you do have a chatbot to discuss about mental health issues, but using voice, the chatbot could also internalize potential flagging of issues. Do you think it could be, it's a potential pathway? It's too risky? What are the pros and cons?
Yeah, so a few of these platforms reached out to us for this exactly. So in at least for the one who reached out to us, that's a use case we fully support because we really focus on the measure and they focus on the support. And I think we really need the two together. And so yeah, I'm really happy about this partnerships. Whether it's in that direction, so our technology being integrated in the solution, the support solution, or us integrating such support for follow-up in our recommendations, which we are planning to integrate more and more.
So, for example, in the Teams app, what are the recommendations again in the Teams
So in the
plugin?
Teams, as of today, you have some recommendation like to do simple breathing exercise or some lifestyle recommendation, but we prefer to have them much more actionable. So typically when it's deployed in a company, there they are customized with their resources. So oftentimes they have this phone line employee could call if they need help, and this is completely anonymous. There is a secret with respect to the company, and they have like massage. They have many things to offer, and we include them because when you have a link where you can book a massage, you tend to do it more than when it's okay, we suggest you to do this exercise. So that's one way to make it really actionable. Now in our app that is not related to any company, that's where we are trying to include more and more actionable support, but we want to ensure it's free for the users. So that's what we are figuring out right now.
So what's the cost actually? Do you have some evaluation of the cost for one, I don't know, voice analysis once you train the model and everything for one more analysis? Do you have an evaluation, or is it just almost costless? I don't.
You mean in terms of, I'm not sure I understood.
Okay, basically, because what's the additional cost of doing one diagnosis and filtering of voice? So basically, it's the so I guess you have a model that will analyze this for a certain amount of time. How long is it? How complex it is? And do you have some basically evaluation based on electricity bills or I don't know of doing one more analysis? Because it sounds you have the training, which is costly. You have a whole company, of course. You have infrastructure. You have the salaries. So all this is included and should be internalized for one more analysis. But just once everything is done, I'm just curious. This question is basically also related to the capacity to scale. If at some point you have a government that want to subsidize this and allow anyone to do it, will it be basically costly or not to do this at scale for the population of Switzerland?
So it really depends on what is analyzed. So depending on the health insight, the models have different weights. They are not some are lighter, other less. So it depends really which one we're talking about. And then also between some health insight, there are synergies where when they run together, we can have one part of the processing that is that we do only once for the two prediction, and sometimes it's not the case. So it really depends. So that's why also we offer our solution in terms of module, what we call a module. So also the pricing makes sense there for clients and for us. So I cannot tell much about that. Also, given the fact that we do a lot of optimization. So as of today, we have some models that are a bit optimized and other which are not optimized in terms of processing at all, but we wanted to release them as early as possible. So it's really vary, and the answer I would give you today would probably be completely different in a couple of months.
No, I see. And yes, and actually, it's not very reflecting, and it could be misleading for people listening if we say, okay, for a optimized model, the inference part is almost costless. It's not, but it's very low because indeed, as you said, you have a lot of work, ongoing work, constant work to ensure that it's working to optimize. So indeed, it will be actually probably misleading, but I can imagine. What's basically how do you foresee the future if you want to basically that's one of the last really main thing I want to know about it because it sounds really more than promising in life changing for probably many people. And how do you foresee the future? Are you more optimistic? Do you see I don't know.
Yeah, no, I'm quite optimistic. Otherwise, I wouldn't be doing that. I think we are starting to have a lot of tools, like I have some wearables as well, that help us monitor our health and make better informed decisions about it. And I really hope such tools, so probably a wearable can be quite expensive, but voice analysis at scale, depending on how it's deployed, especially when it's combined with telecommunication infrastructure, we can do it for much cheaper. Because when you were asking about the processing, there is everything about training the model, but then there is everything that is happening in the app, which is also about checking quality of audio, etc. just sitting one thing among many other, which increased a lot the processing time and cost. And so I think thanks to such tool, and there are also like other technologies that help to measure our health. And I think now we are starting to have tools that allows to do that for a much cheaper rate and make it accessible also in communities that are not just in Europe, US, China, for example, but also in what we call the global south, like LATAM, so Latin America and Africa. And I think this is going to help increase our globally our health in the society. And that's also why I'm really willing that this technology gets adopted further, because I really believe in its impact. Now we have a lot of, we have the infrastructure, we have the resources to support health, whether it's mental health, physical health, but it's not always directed to the people who need it the most. So just in the well-being scope, I was mentioning in an enterprise setup, you can have this massage session, you can book, but usually they are the people who feel like they have the time to do it, who will do it, while the people who are feeling like they are burning out, they're like, I don't have the time to do a massage, and they won't do it. But if you put it under the eyes, you say, okay, look, your stress, your anxiety, your fatigue, this has been increasing lately. We suggest you book this. This is taken, it's your company paying for it, take it. And these people will, at least what we see is that they tend to do it, while if there wasn't technology that's measure objectively and tell them and suggest them, they won't do it. And so that's what we see, not just in the enterprise field, but also in terms of global health. And even in countries that are considered like less developed, now there are a lot of resources, a lot of support as well, which makes such technology useful, because without support, you detect, if you don't have way to treat it, it's not useful.